Good morning, dear friends. Myself, Dr. Abhishek, and I am here to give you a brief overview of subdural and epidural hemorrhage. This is intended to be a very short video that will help you learn the key pointers related to the concept. Now, let us have a quick recap of the meninges of the brain. As we all know, that meninges is the protective outer covering of the brain. It consists of three important layers. The outer one is the dura mater, then arachnoid matter, and then pia mater. Above the dura mater and between the skull is the epidural space, and below the dura mater and above the arachnoid matter is the subdural space. Then comes the subarachnoid space, which comes between the pia mater and the arachnoid matter, which holds the CSF. Dura mater consists of two layers, the internal layer and the external layer. The internal layer lies above the arachnoid matter and separated by the subdural space. Then external layer adheres to the inner layer of the skull. Now the two layers of the dura mater, the external layers and the internal layers, they lie close to each other and divide into meningeal folds which help divide the sections of the brain. As we all know that the fox cerebri, it divides the two cerebral hemispheres, and the tentorium cerebelli, which divide the cerebral hemispheres from the cerebellum below. This concept is important to understand the brain herniation, which occurs due to increased intracranial pressure. Now coming to the cause of subdural hemorrhage. The cause of subdural hemorrhage is the rupture of the bridging veins, which occurs in the subdural space between the dura mater and the arachnoid matter. In the next slide, we will see the causes which lead to subdural hemorrhage. Now, the important causes of subdural hemorrhage is basically a head trauma. It can occur during acceleration, deceleration injury, or due to shaken baby syndrome, or it is very common in rugby players also. In acceleration, deceleration injury, suppose a vehicle stops suddenly, either due to accident or due to some obstruction. The motion of the skull is suddenly stopped by the shoulder restraint, but the recoil causes rapid acceleration in opposite direction and a second stop, due to which the brain impacts with the skull, causing injury. Then in shaken baby syndrome, when a baby is violently shaken, so this can also lead to damage. Then rugby players, it is also very common. The other causes can include alcohol abuse, wherein the veins become thin-walled, which are likely to rupture. Then in elderly there is brain atrophy, wherein the brain shrinks in size, so the bridging veins are stretched over a larger space, causing rupture. The active bleeding can lead to hemorrhage, while the collection of blood can lead to hematoma. Now we will talk about the progression of subdural hemorrhage. Since the damaged bridging veins in the subdural space are under low pressure, so the bleeding will be slow and there will be delayed onset of symptoms. The acute phase lasts for up to 2 days, the subacute phase lasts for 3 to 14 days, and the chronic phase lasts beyond 15 days. On CT scan, it appears as a hyperdense white mass which is whiter than the surrounding area. All of this can lead to increased intracranial pressure. The large subdural hematomas can also cause midline shift and displacement. Now the increased intracranial pressure can also cause brain herniation, which can be broadly classified into two types. One is the supratentorial herniation, which occurs above the tentorium cerebelli, and another one is infratentorial herniation, which occurs below the tentorium cerebelli. Now an important type of supratentorial herniation is the subfalcine or the cingulate herniation, which is the herniation of the cingulate gyrus below the fox cerebri. Since the frontal lobe is involved, it affects the areas supplied by the anterior cerebral artery, which can cause contralateral lower limb weakness and sensory loss. Another one is the uncal herniation, which is the herniation of the uncus in the temporal lobe below the tentorium cerebelli. It affects the area supplied by the posterior cerebral artery and the third cranial nerve, that is the oculomotor. So it causes down out blown pupils. Then tonsillar herniation, it is the herniation of the cerebellar tonsils downwards to the foramen magnum. Since it affects the brainstem area, so it can affect heart rate, respiration and consciousness. It can also lead to coma and death. Then upward cerebellar or transtentorial herniation, which is the herniation of the cerebellum above the tentorium cerebelli. It can lead to ataxia and nystagmus. Then central or transtentorial herniation, which is the herniation downwards towards the brainstem. It can lead to decorticate posturing and decerebrate posturing. In decorticate posturing, the arms are bent towards the center of the body, and in decerebrate posturing, the arms are straight and tense and held parallel to the body, while the wrists are flexed. Now coming to the epidural hemorrhage, we have already discussed the basic anatomy of the meninges. Epidural hemorrhage is the bleeding between the dura mater and the skull, and it is caused by a serious head trauma and rupture of the meningeal arteries. The most common site of epidural hemorrhage is the pterion. It is the junction of the frontal, parietal, temporal and sphenoid bone, and it is located just above the middle meningeal artery, which is the most commonly involved artery in the epidural hemorrhage. Now when the meningeal artery is torn, the blood collects between the skull and the external layer of the dura mater. And since the dura mater is adhering more tightly to the skull, the epidural hematoma cannot cross the suture lines. Also, since the bleeding occurs under low pressure, the bleeding accumulates very slowly, leading to lucid interval in epidural hematoma. That is, the lucid interval means that there is several hours pass before the onset of symptoms. Now the symptoms of hematoma include loss of consciousness, which can occur immediately after the injury or in ensuing days. In epidural hematoma, there may be a lucid interval. Headache and vomiting is common. Then focal neurological problems leading to muscle weakness and sensory loss depending on the location of the hematoma. We have already discussed the herniation part, which occurs due to increased intracranial pressure. So the symptoms depend on the location of the hematoma and which part of the brain is affected. Now coming to the diagnosis of subdural hemorrhage, it can be done through computed tomography or the CT scan. Both the epidural and the subdural hemorrhage or the hematoma will appear as a hyperdense white mass, which is whiter than the surrounding brain tissue. If there is an acute subdural hematoma, it will appear whiter than the surrounding area in crescent shape. When there is a chronic subdural hematoma, the surrounding area will appear black, while the hematoma, the chronic subdural hematoma, will appear lighter black. While if there is an acute on chronic bleeding due to rebleeding in the bridging veins after chronic hematoma, the rebleeding area will appear as white, while the older bleeding will appear little black and the surrounding area will appear black. Now how to distinguish between an epidural hemorrhage and a subdural hemorrhage on a CT scan? So we have to understand the basic anatomy first of all. In epidural hemorrhage, it occurs between the outer layer of the dura mater and the skull. Now since the outer layer of the dura mater is firmly adherent to the outer layer of the skull and the sutures, so the epidural hemorrhage will never cross the suture line. So it will form a biconvex shape. While in subdural hemorrhage, since it is located between the arachnoid matter and the inner layer of the dura mater, it will follow the contour of the brain and it will cross the suture line. So it will form a crescent shape. Now this is a good mnemonic to understand the imaging differences between subdural hematoma and epidural hematoma. Now if you remember a banana, it is concave shaped. So the subdural hematoma, since it is following the contour of the brain, it crosses the suture line, so it is crescent shaped. While in epidural hemorrhage, it will be a convex or a lens shaped because it cannot cross the suture line. If you can remember a lemon, so the epidural hematoma looks like that only. Now coming to the treatment, the small hematomas are drained through a catheter drilled hole, that is known as the burr holes, and blood is allowed to drain through pipes. Then it is also used for chronic hematoma. Craniotomy, wherein a section of the skull is removed temporarily. It is used for acute subdural hematomas and also for large hematomas. Thank you.